All right. Well, thanks everyone for coming again, and thanks for your questions. Keep them coming, and certainly, if you have questions on, when you leave here and you say, oh wait, I should have asked this. We're all very available. Bob and Marianne know how to get a hold of us, and we've all provided emails, and so we're happy to answer questions and for as they come up. So. All right. Okay, so the first question says, I've been on 120 milligrams of lanreotide twice a month since 2017. Now my liver is showing damage, ALT of 80 plus, a crisis of cholecystitis. Are there any links? Thank you and great conference. So thanks for that question. Dr. Maluccio, do you want to take that one?
Okay, can you hear me? Yeah, so there's totally a link. So somatostatin receptor analogs, like octreotide or lanreotide or sandostatin, cause cholestasis. It's the reason why it helps your diarrhea is it just slows everything down. And so if you're on higher than average doses, then slowing down the juices coming out of the liver. Now, an 80 would not be lighting anybody's house on fire, but the gallbladder dysfunction is very typical. We will routinely take out the gallbladder when we operate on people, especially with midguts that live a long time on somatostatin receptor analog therapy in order to keep it from happening. We have a very low threshold for taking out the gallbladder when people start having symptoms or signs of gallbladder dysfunction, which if it doesn't have to be gallstones, it can just be dysfunction of the gallbladder. We'll usually document that on a HIDA scan, but we have a low threshold for taking out the gallbladder, but there is clearly a link between, one, cholestasis, the slowing of all of those fluids over time, especially if you're on above average doses, and then obviously part of those drugs' mechanism of action does alter a bit of your carbohydrate metabolism, raises A1C levels even in normal people, and so therefore if you're prone to fatty infiltration of the liver, it's not going to make that any better. So in answer, yes, there's a link, and two, we have a low threshold for taking out the gallbladder. Anything to add to that?
Well, it's part of the NCAN guidelines is if you're in the abdomen for any reason on a patient with a neuroendocrine tumor, it's going to be on long-term analogs. It's going to be on long-term analogs. Take out the gallbladder while you're there to prevent this from happening down the road, as well as if you're going to get liver-directed therapy where they squirt stuff up into the artery to the liver, that same artery goes to the gallbladder. And so if that stuff goes up into the gallbladder, you can get a pretty intense, severe necrotizing gallbladder attack where the gallbladder gets gangrenous and dies, and it's emergency surgery, and it's just not any fun. So in general, if somebody's talking about operating on you for a neuroendocrine problem in the abdomen, say, take out my gallbladder while you're there. And they'll say, why? Now you know why.
All right. Next question. As a NET patient, should I be concerned about tumors on my ascending, descending, and aortic arch? I think, is this all vessel related? Is that what this is about, Dr. Boudreau?
Well, it's not uncommon to have lymph nodes involved on that chain. The lymph nodes tend to live, and the lymphatic channels tend to travel with blood vessels. They kind of hang out together. And so people that have a challenge with metastases to lymph nodes, it travels up those chains, and they typically land along the blood vessels. For the most part, we haven't found them to be particularly problematic unless they get really big. And if they start compressing on things and squeezing blood vessels and stuff, then it might make a case for to go to take them out or try some other methodology. The problem is we don't have a lot of good options to shrink these things. Like we see sometimes PRT sometimes shrinks things. Some of the oral chemotherapies sometimes shrink these things. But we don't have anything that consistently will shrink these things on a predictable basis. So that sometimes is a bit of a roll of the dice.
Great. Dr. Gupta, how are small cell and large cell diagnosed, and what's the difference?
So small cell and large cell are going to be diagnosed by the pathologist. When you have your biopsy, this is most likely going to be after a biopsy because I would be surprised if you've had surgery for small cell or large cell. So this is going to be on after a biopsy, and the pathologist is going to be the one to tell us if it's small cell or large cell neuroendocrine carcinoma. And really, to put it simply, the only difference between is the size of the cell. So the small cell is small and the large cell is large, and they're treated pretty similarly.
All right. Emily, maybe you can answer this one. Are drugs like Ozempic or okay to use to help control A1C in NET patients?
So this is where I would probably refer to our endocrinology folks. I think that for me, the short answer is maybe. So this is when we lean, it's a multidisciplinary approach, we lean on our colleagues. So I would not prescribe that myself necessarily, but I would work with an endocrinologist to say, is this going to be the best one, for that patient? So the short answer is maybe.
Yeah, I think from my standpoint, usually I'll defer to whoever's writing for this, whether or not it's the primary care doc or the endocrinologist. I mean, I think from a NET standpoint, they're not going to interfere with anything I really do. If there's ever a question, we have our pharmacists weigh in, and we're always messaging our pharmacists. Is there any interaction between this and this? Depending on the circumstance. And I think these drugs, we're going to be seeing more and more of these things, and it seems like we're getting a lot of patients on these.
Yeah, I would say, so for people on Ozempic, we have learned the hard way recently, is that if you're having an operation and you have been previously taking those medications, we can have some significant problems with the bowel not waking up at the same pace, delayed gastric emptying, readmissions for things that look like partial bowel obstructions. That actually is recognized. I think that in the bariatric space, they say to bring the patients off for a week. I think that for other types of diagnosis, we're changing our practice pattern, taking people off for at least 2 weeks beforehand, because it does seem like we're going to start to better understand how those class of medications interact with some of the other stuff that we're just so used to doing. So we understand when to take someone off Plavix, aspirin, or whatever, but then I don't think any of us really thought about, like, oh my gosh, do I have to take them off that medication?
I think, Rob, you highlight too, I think the importance, we're very lucky. We have a clinical pharmacist that works literally in clinic with us. And, those types of meds, and we get questions like this, not just for Ozempic, but all kinds of other meds. Is this okay to take? And this can interfere with my treatment in any way? And so, we work with her to make sure we're not going to do anything that's going to be harmful. There are times where we might not be able to say, we might have data for something, but we can sort of advise, what we know, this is safe as far as we can tell. Or if there is a contraindication, we're very much going to tell you that and try to come up with another plan.
All right. All right. This one was directed towards me, and maybe Emily can weigh in on this as well. Multiple lung nets, grade 1, typical. Cough and shortness of breath, but not debilitating. What are your thoughts on monthly lanreotide injections versus watching, waiting, or no treatment? So, I didn't really mention this in my talk at all, just because of time constraints, but this sounds like an entity, a rare entity called DIPNEC, which stands for diffuse idiopathic pulmonary neuroendocrine cell hyperplasia. What we think this is a pre-malignant condition where patients can have overgrowth of the usual neuroendocrine cells that line the airways. When this happens, sometimes people can end up with respiratory symptoms, primarily cough or trouble with the breathing. The cough can be really debilitating. It tends to happen in women, middle-aged, and can get misdiagnosed. I think you've heard a lot about misdiagnosis today. But get diagnosed with asthma or COPD or other entities. And it isn't until somebody actually does a scan, which the scan will usually show multiple nodules within the lung, and also evidence of collapse of some of the airways, so something called air trapping. The scan is pretty classic, but it's usually diagnosed off of a biopsy, and the biopsy will show overgrowth of the neuroendocrine cells. So so the treatment for something like this is sometimes no treatment. Sometimes it depends on the symptoms, and sometimes, again, we think this is a pre-malignant condition where these cells can grow into neuroendocrine tumors, and then if they do, then we treat them like neuroendocrine tumors of the lung. Interestingly enough, what we have found is people who are really symptomatic from this, they do, in some cases, derive benefit from the somatostatin analogs, so either lanreotide or octreotide. And that can help, one, with the symptoms, but there's also data to suggest that it may help with the lung function, so it may improve your pulmonary function testing. So we're still learning a whole lot about it. Emily can talk a little bit more about our patient population, but it's a pretty uncommon entity. But I think we're seeing more and more of this.
Yeah, I think it's similar. I forget on whose presentation, the slide about incidence, maybe it was yours, Rob, and how it's sort of climbing. I think, DIPNIC is something that is even rarer than neuroendocrine tumors per se, but I think, at least in what we're finding, we're seeing a lot more cases of it. I think we're up to like 66 patients that we've identified with this. And we're trying to sort of put together some data and figure out a little more about it. But I agree. I think there's can be symptomatic benefit from the somatostatin analog. But if your symptoms aren't that bad, I think watchful waiting, observation is also reasonable. And so hopefully as we gather more data, we'll be able to answer that more precisely.
All right. That's the list of questions. Are there more questions?
Everybody says that, but nobody else will hear you.
Does histotripsy have a specific amount of times you can have that done in your lifetime, like PRRT does?
Yes. How many times the insurance company?
I like that one.
We don't know what the upper limits are, but so far they don't seem to be.
You.
Wait. You have to speak into the microphone because nobody.
So the question you heard was how many times can you do histotripsy? And the answer was as many times as the insurance company will approve it. That's been our rate limiting step to get people treated, has been a real fight with the insurance companies. Even though it's FDA approved, it's Medicare approved, and it's UNOS approved, that's the big network in the sky that keeps the list for patients that are getting ready for transplant. It's used to downsize liver tumors to get patients transplantable, and it's an accepted methodology for that.
So the other part of your question was interesting too, the way you phrased it. You said, does histotripsy have a number of times, a limit on the number of times you can do it like PRRT? Do you want to address that, Mary?
Oh, well, I wouldn't necessarily, you have a limit on PRRT either, except for the same reason. So you, in Europe, they give lower doses multiple times for PRRT. You get 10, 12, 14 over a much longer period of time. And some of the clinical trials are looking at PRRT. Well, they were specifically dose it. They do dosimetry before each and every dose so that they're almost personalizing each individual treatment. It's the U.S. that is limiting, yeah. And so the U.S. is what ultimately says up to this point we don't have a problem because it's considered a standard of care. Then we're kind of allowed to get to leverage for 2 additional doses, but you have to remember that what is the value, like the 2 additional doses that you would able to leverage for the beta PRRT when the clinical trial people had already gotten 4 doses of the beta PRRT and on trial got 4 more doses of alpha. So I think it's going to all be toxicity related because you can get pretty significant myelosuppression. I think what we didn't mention in some of the histotripsy talks, because it's just really new, is that histotripsy very much respects the difference between what you're hitting, which is a tumor, and the collagen content or the particular texture of something right next to it. So it will literally continue to go around, but that as it goes to an interface between what you're hitting and more normal structures like bile ducts, blood vessels, and things like that, it's going to hit it almost like this artificial wall there that's saying, oh, no, 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 this texture's different. So you would imagine like the prostate and the pelvis, I mean, that's extraordinary. What I failed to mention, or what any of us failed to mention, is that the liver component of histotripsy, for which it is FDA approved, is probably less exciting than how we would potentially be able to do PNET. To be able to maybe not have to operate on a pancreas that doesn't like to be operated on, and we would be able to guide a non-invasive treatment and effectively treat a PNET, would be life-changing. Whether or not we do IRE versus microwave versus liver-directed therapy versus cryo versus histotripsy, I think that the effectiveness on it on that tumor is all going to be about the same. And then, yeah, we'd all love for this immune thing to sort of materialize, because that would mean that we would be able to use the least invasive in order to get the same outcome.
Right. Now, if somebody's done the PRRT before, does that eliminate them from being able to do the histotripsy?
No.
Or is there have to be a time
Can you
between
repeat the
two?
question? Nobody is hearing.
Oh,
you.
sorry. She said if you've gotten other treatment before, nothing's mutually exclusive. If you've got another treatment before, would that limit your ability to get histotripsy? And the answer is no. Histotripsy literally is just going to cavitate what is within its treatment zone. And whether or not that is something that has previously potentially been exposed to PRRT, there are few, if any. I'm trying to think of any limitations other than location. Some of the ways high up on the right-hand side is tough. When we've treated through the ribs, we have successfully treated several now through the ribs. Probably not quite as satisfying, a little bit more cumbersome. It can be done, but it's just not as clean as just being able to maybe do an IRE or microwave probe. But that if you can see it on the planning ultrasound, histotripsy is pretty much like locking the car into the car wash. Once it's in there, the car goes all the way to the end.
Yeah, the thing about the histotripsy is you have to have what they call an acoustic window. And so there's things that may be in the way of the sound beams traveling that you wouldn't necessarily want to blast, like the heart. Sometimes that's in the way. The stomach, because that's all sitting right on top of and next to and underneath on the side of the liver. The ribs can be problematic because the bones kind of block the sound waves. Lungs, because they're full of air, sound waves don't conduct well through air. So if you're trying to get something posterior and the lung hangs down behind the liver, which it does, that is a problem. So it's about having the acoustic window to target the thing. And so there are some locations in the liver, and depending on the person's shape of their rib cage and the shape of their diaphragms and the shape of their liver, will dictate where some tumors are not targetable. But the current histotripsy 2.0 is coming out, and then we'll be able to have a little more flexibility in where we can reach in terms of depth of invasion and penetration and size of tumors we can treat. Also, there's currently work being done treating kidney tumors, and very soon there'll be a trial opening looking at treating the pancreas with this technology, which got everybody kind of jazzed because nobody likes to operate on the pancreas. Kind of facetiously, but
We have a question.
it is it is more of a challenging operation. There are more complications after pancreas surgery, and that's why a lot of people give pause before they just kind of haul off and go do stuff to the pancreas.
So my question is around lanreotide. I've heard that you can be on lanreotide for the rest of your life.
Probably.
When is an opportunity that you could come off it? I mean, what would, in any one of you, in your opinion, what would you need to see to say, I think we can take a break from lanreotide, or I think you can come off?
Go ahead.
Garima?
So I think even before you start lanreotide, the question is, do you need to go on lanreotide, right? So not everybody needs to go on lanreotide. If you have had stable disease, you have low burden of disease, that you may not need to go on a somatostatin analog right away. I think the things to consider if you have been on lanreotide for a long period of time and you're maybe having side effects and you want to come off lanreotide, I think it's kind of an area of controversy, like, do you need to really continue it if you have had progression and you don't have carcinoid syndrome that it was helping you with? There is, these practices differ. You can continue it if you're tolerating it okay, or you can just go to second-line treatment.
And then one other thing that we didn't, because were the Crinetics people here? I can't even remember. So the clinical trials, once again, the clinical trials are coming down the pike where the oral medications are getting people off of the injectables. So, and still with very good control. So the trial, it was a phase 2, so effectiveness. I don't think there's any doubt that it's going to be a positive trial, meaning that it's going to at least meet the endpoint of controlling symptoms. They had to use symptom control because to wait for people to progress would have taken way too long for them to get the drug through the FDA. So I think they met the endpoint, which is flushing diarrhea significantly impacted that, and that's going to be oral. So, but in order to get onto that trial, you had to have carcinoid syndrome despite being on somatostatin analog therapy, okay? You had to be willing to come off of it, which for people that have been on it a long time, that was either like hallelujah or like, ugh. And yet those people have done, our 3 people have done quite well on that trial. So usually I'll tell people that it looks like the future is bright on being able to at least say, hey, I don't even qualms if people want to come off of it for several months. It's not like how we look at other chemotherapy that by coming off it, somehow the cells are going to be like, whoop, whoop, now we're going to figure out how to get around that drug. You could go back on it and have it be as effective. And so I really don't have strong feelings about people coming off of lanreotide. Now, to understand the impact of that, it takes like 4 months to get the drug out of your system, so that if you're going to come off it and do that experiment, I would say you're coming off of it for like 4 to 6 months. And then we will usually follow it with a PET scan, because that's our needle in a haystack scan, so you can understand then at the functional level. But then I'd also tell you that the oral medication, I don't think there's any doubt in our mind that that's going to become available.
Yeah, they said they were starting phase 3.
Yeah, and just to give you an example, I had a patient who I met recently. She had been on lanreotide since 2018, and last year she decided to come off of it. And that's fine. I mean, she's doing fine. Her scans are still stable, so there's really no reason to continue it if you want to take a trial of coming off of it.
I personally have been on all of them over the last 23 years. And I have syndrome really, really bad. I can't do without it. So sometimes people do well with lanreotide. Some people do well with standostatin. Some people do the sub-Q. I was on the standostatin. I was on 4 times the normal dose for 8 years, and it stopped working, and I was giving myself sub-Q. They did try to put me on lanreotide. I could not handle lanreotide. I have lupus, and my joints started swelling. I started getting headaches. I was totally uncomfortable, and I had to come right off. So each person responds differently to the medicine. So if you are having issues maybe with the lanreotide, you could ask to try the standostatin instead, or take the break. But that's my experience.
The thing is, coming off therapy, we never know who may suffer detriment. if the drug is keeping things stable. And so my caution is if you're coming off of the drug, either lanreotide or octreotide, it will require close monitoring for a period of time afterwards to make sure things don't ramp up and start progressing at perhaps a rate that you would not have otherwise appreciated while being on the drug. So it always makes me just a little bit nervous to take somebody off and say, well, see you later, you're okay, don't do anything. It's not that you don't do anything, you still have to be surveyed and monitored and get scans and stuff like that. That's my thoughts.
Question here.
Okay, one quick time going back to the histotripsy. If you have innumerable tumors, some of them very small, others softball size, I understand the acoustic window, but they're in both lobes. Is histotripsy going to eventually be able to handle, 30 tumors in your liver? Would that be an option?
I don't think I would recommend treating 30 tumors at a time because we have seen from some other reports and other investigators that if you treat too much tumor bulk, you get a kind of a tumor necrosis factor and some other evil humors that are released that can cause some kidney dysfunction and some other problems. I think because the nice thing about it, it is so non-invasive and so basically benign that you would fractionally treat the liver. And if you can image them, you can target them. And we've treated tumors in every segment of the liver now, both lobes, all 8 segments. So it's about the targeting. And so this may be a thing we're going to see a lot more of as time goes for not just this disease, but all sorts of tumors of the liver. And then when the other shoe drops, if we can get FDA approval for other extrahepatic sites of treatment. I foresee that people that get sarcomas and these tissue cancers in the muscles and their extremity, for instance, in kids, the treatment was an amputation. Now you may be able to just melt the tumor off of the vessels and the nerves and save the extremity. It's things like that. So I think there's a lot of stuff we're going to learn about this technology. If the preliminary outcomes hold and the side effect profile remains as low as what it seems to be, I think this is probably going to be a much more commonplace procedure being performed for all sorts of different types of tumors. That's my guess.
Yeah, and then Boudreau had the images of where you have mesenteric masses. I think what we're really hopeful is that as they develop the technology, we'll have a head, we call it a head, is that you'll have a head that either you'll be able to use in the operating room or you'll be able to put through a laparoscope and the base of the mesentery, because the blood vessels are going through those tumors. And when we're operating, it's a little hard in what he does. He's like the master of the base of the mesentery. Hard to say, well, how much is going to be more detriment than it's worth? If you were able to then use a histotripsy probe now under direct vision, so you're putting it right on there just like you're doing a OB one, and you will be able to, just because the content of that tumor is going to be vastly different than the collagen content of the blood vessel that is somehow getting entrapped by that tumor, oh yeah, that's going to be a total game changer to an operation that can be very complicated. So, but in answer to your question is that it's not meant to go after miliary, that tiny little distal thing. We go after the softball, and then in hopes of the immune thing panning out, if you were to get that critical mass of tumor destruction, and then hoping that the miliary stuff is so pathetic that it would be more prone to do this. But you got to remember that it's new, and liver-directed therapies that under Marsala went have an 80% objective response rate, but even they're not good for miliary when you're shooting it into hundreds of tumor, which is why you have things like liver transplant for metastatic neuroendocrine, because, but a golf ball size thing, we should be able to totally see that. You would just focus on that and kind of hope that the other stuff falls into place.